This is Focus with Jack Cottle.
And good evening, I'm Jack Cottle. Welcome to this month's edition of Focus. This month we're talking about the opioid crisis here in the Black Hills and also, to some extent, around the country. Three guests with us to talk about that. Brian Zabe is the Assistant Director of the South Dakota Division of Criminal Investigation, also a member of the South Dakota Prescription Opioid Abuse Advisory Committee. Dr. Michael Hewitt, he is with West River Anesthesiology. He is also a board-certified pain specialist. And Trish Peterson, she is with Addiction Recovery Centers of the Black Hills, a licensed addictions counselor and clinical supervisor with 15 years of experience in that field. Well, the Centers for Disease Control says in 2014, more than 47,000 people died of drug overdoses in the U.S. That was a new record. More than 3 out of 5 of those deaths were from opioids. The numbers relatively low here in South Dakota, but they are growing. The South Dakota Department of Health says there were 37 opioid deaths in the state in 2014, up from 15 just back in 2007. And we're talking about opioids. We're talking about things like heroin, fentanyl, oxycodone, hydrocodone, codeine, and morphine. Brian, we're going to start with you. Just how bad is the problem here in South Dakota, in particular in this area of the state?
I think, Jack, that there's reason to be concerned. I think that drug use is prevalent in all areas of the state. I think that there's a couple of cases that we've had to experience here this summer that would bring some of this to light. There was a case here in Lawrence County in June where 9 individuals were indicted for over 50 counts of ranging from distribution to possession to 2 deaths that were involved in a opioid-related distribution network, primarily fentanyl. And also we had a case this summer, earlier in the summer in Chamberlain. We had about 20,000 fentanyl pills that were seized from an individual in Brule County, South Dakota. And a lot of these examples are of drugs that are coming to South Dakota, primarily through ordering on the dark web, which is a section of the internet with special software that people can order about anything they would ever want, which is concerning. But a lot of those type of drugs and those examples come to South Dakota through the mail or some sort of courier system. Recently, the President of the United States issued a national warning of a health epidemic with opioids. I think there's concern here and evidence here in South Dakota. Currently, our primary battle is with methamphetamine. We do see cases involving prescription drug misuse, abuse, fraud, forgery, theft that we do deal with. About 30% of our cases at the DCI level deal with some sort of pharmaceutical-related drug. And as you mentioned, being on the advisory committee with the opioid abuse at the state level, these are things that we're looking at. How do we do a better job collaborating? How do we do a better job sharing information inside of law enforcement? How do we do a better job working with treatment? How do we do a better job working with pharmacists, the Board of Pharmacy, and the medical folks and prescribers across the state? As I think this is something that we need to get ahead of and something that we need to take seriously.
Dr. Hewitt, from the medical perspective, what do you see? How bad is the opioid issue here in the Black Hills?
So here in the Black Hills, there's no doubt that it's an issue. When you look nationally, though, we've seen opioid prescriptions go up. They've almost quadrupled in the last 20 years. Traditionally, in the Midwest, we're a lot less than nationally. We don't prescribe as many opioids as the rest of the country. And that kind of holds true for this problem also. We've definitely seen an uptick in prescriptions being handed out in the Midwest, and we've seen an increase in overdose, and we've seen an increase in abuse, but it hasn't been quite to the extent that the rest of the country has seen. And when you kind of pare it down to the Midwest, South Dakota, we're typically kind of have the lowest rate of all of those. So it's still a problem here, but something we definitely have to get ahead of, but it's not as much of a problem here as it is in the rest of the country.
Now, Trish, you deal with this from the treatment side of things. As you look at it from that, how big of an issue is the opioid crisis here in this area?
I would say the percentage is high. Most of the clients that we work with, most of them have had a prescription, and at some point after having a physiological dependence on that prescription find themselves becoming very dependent on it, which means they're abusing their drug of choice. That's one side. The other side is people who use methamphetamine. Part of helping them come down from withdrawals is they'll counteract that with opioids to help lessen the withdrawal symptom. So in the last, probably I would say 3 to 4 months, the assessments that we have done, the people that we currently have in treatment and or have referred for higher level of care, the percentage has gone up. I don't know exactly, but it's been high, you know, both for opiates and then the combination with methamphetamine.
Are there particular opiates that seem to be a bigger issue in this area than others?
Fentanyl, oxycodone, Oxycontin, Percocets, those stand out the most, yes.
Now, the prevailing notion in the past that people that got into opiate addiction started with heroin, moved to something else. Now they seem to be starting with prescription drugs and staying with that. Is that what you're seeing as well?
Yes. Yes, and the unfortunate part of all this too, part of that is if the prescription runs out, if they're not able to fill, then they go looking at it on the street. And they'll pay whatever they can finding it on the street, so that a big part of that is so they do not have to experience the severe withdrawals. You know, so to not experience that, I'm going to keep using. Yeah.
Now, Dr. Hewitt, you, again, a lot of people starting with the prescription drugs. So what role does the medical community play in trying to keep that from becoming more of a problem than it is?
So our role is when we give a prescription of opioids, we want to make sure that that is used appropriately, it's used in the right patient. And ultimately, we don't want it to end up in the hands of somebody who's going to abuse it or somebody who's going to have an addiction problem with it. Now that's a tricky thing because, you know, my specialty is chronic pain, and we have many people in this community that really suffer every single day from pain. And so what we're trying to do is we're trying to lessen that pain through many different modalities, one of which is opioid medications. Now that can be really tricky to try to make sure that those medicines stay appropriately in the appropriate hands and not end up, you know, in somebody who's going to abuse them or take advantage of a family member or whatever. And so that's something that's really tricky for us to try to figure out. But the state has put forward specific guidelines to try to help practitioners to make sure that these kind of stay in the right hands of people that need them.
So what changes has the state made at the state level to do that?
So the state back in about September, October came up with a bunch of different guidelines which we in pain medicine have followed for a long time, but they implemented them across the board. Anybody that prescribes opioids have to follow a specific set of rules, and these rules are geared towards trying to make sure that people who get the opioids are appropriate to have the opioids and try to make sure that they are the ones taking the opioids. And it makes it so that less of these opioids hopefully get in the hands of the wrong person.
Now, Brian, from a legal side, what do you guys do to try to make sure that somebody that has extra pills, they're not going to their friends, their family, whoever, selling them?
Yeah, I mean, there's many different things that there's programs that we have out now, kind of in the educational program side. There's awareness programs that we also are sponsoring through the Attorney General's office. One program is Project Stand Up. And if somebody has a concern that maybe somebody is breaking the law, that they can, it's a text platform, it's an anonymous text platform. They could send a text that maybe provided information that could be helpful if it gets to a criminal investigative point. Another thing that we try to do is a lot of outreach with pharmacists and try to do a better job with physicians so that they understand that there are things that, resources out there law enforcement wise that we would take on an investigation if we needed to, and would work in a collaborative effort to make sure that we would solve whatever that problem might be if somebody's abusing or misusing or distributing some of these highly addictive drugs.
All right, we got to take a break. When we come back, we'll continue our look at the opioid crisis in this month's edition of Focus. I'm Jack Cottle. Welcome back to this month's edition of Focus, talking about the prescription drug and opioid crisis here in the Black Hills. Brian Zabe is the Assistant Director of the South Dakota Division of Criminal Investigation. One of the changes, the new prescription drug monitoring program, been around for a few years now. What kind of difference has that made in trying to keep tabs on where this stuff is going?
Yeah, Jack, I think it's an important tool. It was brought into existence about 2010 through legislation the Attorney General's office sponsored. About 2011, it got off the ground. Basically, it's a tool, it's a repository of prescription information that can be accessed by physicians, prescribers, pharmacists, to make sure the primary goal is to make sure that that information is available to make good decisions on how to help and treat patients that need help. Law enforcement is a partner in that. We do have certain levels of access, not direct access. We do have the ability to ask for information if it's a bona fide criminal investigation, something that comes to us maybe through a complaint from a pharmacist or through a physician or some other form of a complaint. And that data can be useful to help solve, maybe a problem where there is some sort of misuse, abuse, doctor shopping, multiple pharmacy, or somebody seeking and maybe even distribution of these controlled substances. But again, valuable tool, things that we need to continue to use and improve. Right now, my understanding is that we share data inside of the South Dakota prescription drug monitoring program with about 21 other states. We're working on making that available also in states like Wyoming that border us, and also working with Nebraska to try to get their information where we can share information because of individuals who come across, obviously, that come back and forth in the South Dakota. So it's a vital tool. It's something that the Opioid Abuse Committee is talking about, things that, at the legislative level we keep talking about. And my understanding is that now physicians are working hard to make sure that they're signed up as well to get all prescribers and pharmacists using that tool. So it's, like I said, it's very valuable and something that we need to keep sharing, looking at the data to help guide best practices, I think is probably the best word.
Dr. Michael Hewitt is a board-certified pain specialist with West River Anesthesiology. How good of a tool is that for you guys to kind of keep tabs on where people are at, where these medicines might be going?
So the PDMP is a vital tool for us, and we use it every single day. In terms of trying to curb opioids getting into the wrong hands, it really has probably been one of the most beneficial tools out there. For example, before the PDMP, I had no way of knowing if I was going to prescribe a month's supply of opioids. I would have no way of knowing if that person just got multiple opioid prescriptions from other physicians. I would not know. And so now I can look on this PDMP and I can see every opioid prescription that patient has gotten from every provider. And so I instantly can tell, are these being prescribed appropriately or not? It really has been a vital tool. It's one of the measures that South Dakota has implemented. Every physician in South Dakota that prescribes opioids has to be registered with the PDMP, and they should check the PDMP before they prescribe opioids to a patient. And it really has made a huge difference to make sure opioids are going to the right people.
Now, outside of that database, what indications are there for you that there is a problem that needs to be addressed? Outside
of the database?
Yeah.
Sometimes if patients need early refills, that's a sign that they're using more medication than they should be using. We also do urine drug toxicology screens to make sure that they're taking the medication and not selling it, and to make sure that they're not taking other medications that we are not prescribing them, and make sure they're also not taking other illegal drugs. So all of those can be a sign that there's a problem. And so there's multiple things we use when we're trying to evaluate a patient for appropriateness of opioids that we can tell, is this person going to be high risk? Could these opioids possibly be more of a problem than a help for this person? Or are they appropriate for it? And we kind of put all of these pieces of information together to try to decide, is this the right therapy for the patient? But the PDMP has been an excellent tool that we use all the time.
Now, Trish Peterson is with Addiction Recovery Centers of the Black Hills. You've been doing this for 15 years now. From your perspective, what signs do you see? What signs should people look for that maybe there is a problem that needs to be dealt with?
Again, assessing is certainly important. So if a client comes in and we begin talking about prescription, and they may indicate that they have been filling their script more. That's certainly a sign. We certainly look at the withdrawal signs and symptoms, how it's affected their overall life, so that we can take a look at what level of care is in their best interest, as well as collaborating with their doctor to get the collateral information of, is this information correct? Is this person able to make adjustments staying here at home and working, or is that person gain more benefit in going to an inpatient program?
Are there particular challenges in treating a patient with an opioid addiction?
Sure there is. The last thing that an opioid patient wants to feel is withdrawals if they're beginning to abuse them. Terrible muscle aches. I mean, it's a flu-like feeling, and so to get them engaged in how to cope with those withdrawals while waiting to get them into treatment, it's a bit of a challenge, but attainable, yes.
Now, Dr. Hewitt, you were talking about earlier some of the changes in how the process you guys go to prescribe opioids. Are there alternatives? Are there different alternatives now maybe than there were 10, 15 years ago?
Yeah, so part of what got us into this whole problem is in the 90s, there was kind of multiple steps that allowed us to be where we're at today and having so many opioids being prescribed. One of them is pharmaceuticals at the time were telling physicians that the chance of addiction was a lot less. They, in the mid-90s, said it was maybe 1%. And so physicians were trying to help patients with chronic pain. And so they would prescribe these medications thinking that the risk-benefit ratio was there. In addition to that, there was much more focus on treating pain. Well, that resulted in us using opioids maybe more than we should have been using, and resulted in the problem that we face today. Now that we've kind of looked at, well, we should probably be using a lot less opioids for patients with chronic pain, we're looking more and focusing more on a multimodal approach where we're using multiple modalities to try to help treat pain. Now, these include rehabilitative therapies such as physical therapy, yoga. They include interventional therapies, injections. Sometimes surgeries are appropriate. There are lots of other medications that are non-opioid, non-addictive medications that we can use. We use cognitive behavioral therapy. Regional Health has invested a lot of time, money, and effort into trying to help us expand these modalities so that we can offer more options for patients in light of taking away opioids as an option for chronic pain.
Well, who is the typical addict? We'll take a look at that when we come back with this month's edition of Focus. And good evening, I'm Jack Cotto. Welcome back to this month's edition of Focus. This month we're talking about the opioid crisis here in the Black Hills. Trish Peterson is a licensed addictions counselor at addiction recovery centers of the Black Hills. Is there a typical person who's addicted to opioids, or does it run the gamut from rich to poor, men, women, every group?
There's no specific person or race that the addiction is going to pick on. It really is, it covers from, we have seen clients as young as 13 to as old as 64 who have had addiction to opioids. Yeah. And their lifestyle has come from homeless to having a good lifestyle. So it's a bit baffling with what we see in the capabilities that many of these individuals have, and have resorted to opioid abuse. Yes.
Have you seen any kind of common thread as to how these people kind of go over the edge to where they can't help themselves anymore?
I would say the big one is the lack of ability to cope with the withdrawals. That's the last thing that perhaps they want to feel, whether that is they come in and they are doing this on their own, and we certainly want to find out if a doctor's involved, if they're on board with this, if they're coming in and they're trying to do it before something legal takes place. really varies on level of motivation. The huge part of it is I'm on it because the last thing I want to do is experience withdrawals. Yeah.
Dr. Michael Hewitt is with West River Anesthesiology. You mentioned a little bit ago about some of the risk factors that you guys look for. What are those? What are the risk factors that maybe make somebody more susceptible?
Yeah, so there's multiple risk factors, and when we're prescribing an opioid for a patient, we look at those to try to, because the last thing we want to do is give someone a medication who then will develop an addiction problem. You know, a few of those is younger age is typically higher risk, a history of other addiction problems or drug abuse is a risk, and there's multiple others. And before we prescribe any opioids, we always run multiple questions on the patient and do a profile of how high risk are they for opioid addiction.
Brian Zeeb is the Assistant Director of the South Dakota Division of Criminal Investigation. One of the drugs that's been in the news a lot lately, fentanyl, and just how dangerous that is, officers that have just touched it and ended up dying. Are we seeing much of that here, and how big of a concern is that for your guys and your women that are out there on the streets?
Yeah, across the country, across the state, Jack, this is a huge concern. We've changed some of the protocols and practices. We have to invest in more training, have to invest in better protective equipment, and really have to be smart about dealing with a substance that we may find either roadside, in a search warrant, or some other type of evidence that's connected to the case that we're investigating, and it's just it's a lot of caution, to say the least. And we have not had an exposure here in South Dakota. In 2015, we did help pass legislation through the Attorney General's office that brought about first responders to be able to carry Narcan or the medication that could reverse the effects of an opioid overdose. So all of our agents do carry that. A lot of local law enforcement, other state law enforcement do carry that. That could be useful to save somebody's life, or of a citizen, or to save even a law enforcement officer's life that might have been accidentally exposed. So clearly we're starting to see these type of cases. Our main battle, unfortunately, still is methamphetamine that we see across the state. And our goals moving forward are to work smart, to use good information, timely information sharing with all of our partners in law enforcement, and to really attack a problem. If we see somebody who is out to distribute these harmful drugs, we're going to take a very aggressive approach to it.
How important is it to start with kids, getting this in their mindset?
Yeah, I appreciate that question, Jack. I mean, that's a huge issue. I mean, I have 5 children. Okay, so I mean, if you need to start talking about these things with your children young, and we need to help educate other parents. We need to help educate teachers and talk about all types of drug use, alcohol use, marijuana use, meth use, and then that sometimes pills that are that mom and dad need to take to stay healthy. I mean, those are things that need to stay in good, secure locations, so they just cannot be obtained by children.
Is there an easy place people can go? We're just about out of time. Is there an easy place people can go to get the information they need if they don't know about this kind of stuff?
Yeah, I think there's options out there. Board of Pharmacy, probably the Medical Association will have some things on the Attorney General's website. We have those projects we talked about, Project Stand Up, and those other awareness programs.
All right, we are out of time. We want to thank Brian Zeeb, Dr. Michael Hewitt, and Trish Peterson. I want to thank you guys for coming up. Thanks for watching. Hope to see you again the first Sunday night of next month. Good night.